model of the ethmoid is not so good. It'd be really nice if you could see a real skull. But the ethmoid, I think about it like a donkey with big packs on either side of it. And so, or you can think of it like a T with big bags hanging off the two sides of the T. And so the crossbar of the T is the part of the ethmoid that forms, again, part of the neurocranium. It's up inside, and the little cribriform plate that allow the olfactory nerves to go from the brain down into the nose run right through the ethmoid. Okay? So this is one place. The olfactory nerves are central nervous tissue. They're nerves directly from your brain, and they go down into the top of your nose and are chemical receptors for your sense of smell. But that's also how airborne chemicals can get directly into the brain and get through the blood-brain barrier. And that's when people have multiple chemical sensitivities and they get exposed to something, they'll get a headache like right away. And that's because these chemicals can get right in through the cribriform plate. And I've also had patients that have been hitting the head hard enough that when their brain jostled, it sheared all those off and they lost their sense of smell. Do you have anybody that didn't have a sense of smell? Yeah, after head injury or car accident or something? Yeah. And then, so that's the vertical part. And then the bags hanging off are all these little air sacs. And in this model, it's just a solid chunk of plastic. But in real life, they look like little round honeycombs almost. And the bone is translucent, it's so thin. And there's just dozens of little air sacs in there.
Is that the cribriform plate you're describing?
No, a cribriform plate is this plate with all these little tiny holes in it. It looks like like something you would grate your orange peel on.
Oh, okay. And then, but the bone you were describing,
they hang off. They hang off. So I have my little board here. But imagine if you. So the cribriform plate makes a T, like the top of the T, like that. Okay.
Okay.
And then you've got the vertical part that starts with the cristagalli, which basically means breastbone of a bird. And that's the attachment for what? What attaches on the cristagalli? The falx. Yeah, the falx, as it comes down behind the frontal bone, and the bottom part is attached to the cristagalli. Okay? And then it forms a vertical plate, runs down like this. Okay? And that vertical plate, the bottom of it articulates with the vomer to make the top part of the nasal septum, the bony septum. Okay? And then off to either side, like I said, like packs hanging off the side of a donkey, are all those little air sacs.
So what did you say about the other part of the T, the long part?
This is, it sticks up the top as the cristagalli. That's this part right here. And then it continues on down through as the top part of the nasal septum. Okay? And so the ethmoid, remember the frontal bone? And when we did it, we went around the edge of the frontal bone, we talked about the fjord here. Well, that's where the ethmoid sits. It's right up in that fjord, right like that. Okay? And so you can see there's the cribriform plate. So your olfactory bulbs sit right underneath the frontal lobes, and they sit right in there. And they send their little bulbs down through the cribriform plate into the top of your nose.
So is this the cristagalli?
Yep, exactly.
And then these little holes, like little openings, is the cribriform plate? That's what that is? Okay.
And so you can, if you follow the attachment of the falx down, it is continuous with the cristagalli. So that holds the falx, the vertical fibers of the falx are holding the ethmoid up. And that's why I was talking about the falx is the suspensory ligament for your face. Keeps your face from falling off. Okay? So the ethmoid sits up in there like that, but then when this comes in, you see how it fits together like that? So there's the ethmoid, there's the maxilla, and so you can see how it's in between the maxilla and the frontal bone, and also forms a big part of the medial side of the orbit, and it helps to keep the speed. Again, it's in between the maxilla and the frontal bone, so it helps to absorb some of that shock. Now the ethmoid is designed and functions actually exactly like a sponge. So what do you do with the sponge? You can wring it out, right? So first of all, do you see the anatomy of the ethmoid? It's like a T with big air sacs hanging off either side. And those air sacs are very pliable. Those bones are very thin. And so during flexion, what is this bone doing? How's it moving during flexion?
Well, it's this hair bone, right?
Right. So it's going apart, but it's also rotating like this. So what's this part of the maxilla doing during flexion? It's moving that way, right? It's moving superiorly, right? But you got this frontal bone, and remember, the horizontal part of the frontal bone during flexion, which way is it moving? Down. So what do you think happens where these two come together? This is moving up, and this is moving down. What happens to the ethmoid? Yeah. And it absorbs that. It's designed to absorb that shock. So, and it turns out it needs that wringing out in order to be healthy. And if it's not wringing out properly, then you can get sinus infection. Or sinus infection will block it from wringing out. So, and this is something they never talk about in regular cranial classes, is that the horizontal plate of the frontal bone is moving inferiorly, but the anterior part of the maxilla is moving superiorly, and that's a conflict of interest. They never talk about that.
Is it a conflict of interest, or is it designed to?
It's designed to, yeah. So it's designed to squeeze, but they never point that out in most classes. But you can feel it happening. I'll show you how to feel it. Okay, and again, you can actually help that motion. But if you come and look at the model, you can see the anatomy and see how it fits together, and how the ethmoid is again a cushion between the maxilla and the frontal bone, and the sphenoid fits right in there too, and that's why it's one of Sutherland's speed reducers. The sphenoid. What?
There comes the branch of the tree.
Yeah. So sphenoid fits right in like that. So you can see how the ethmoid fits in between the sphenoid and
Maybe I lost it, but can you say a little what the speed reducers really do?
they isolate the facial bones from the cranial bones.
Okay.
So that your facial bones and cranial bones can move somewhat independently.
Okay.
Which is good because there's a lot of forces on these when you chew. There's a lot of forces on them on Saturday night when you're in the bar and you get in a fight, right? There's a lot of infections that go on and that kind of stuff. But if you see how, so there's the sphenoid and the ethmoid together, and this whole system kind of locks in here like this. Okay, so you can start to see how it all fits together. So come and play with these models during lunch and see what you and look and see how it all works. And again, think about what's happening during flexion and extension. See if you can prove to yourself what's going on here. Okay? And so the ethmoid is, you can see how it cuts way back in there. So we don't have any direct access to it because you can't reach it this way, you can't reach it this way, unless you poke somebody's eyes out, you can't reach it this way, because it's way back inside. So we have to work the ethmoid indirectly. And so if the most common restriction that happens with the ethmoid is compression. And so to decompress the ethmoid, what we do is, you know how when we were decompressing the vomer, we had a finger here on the inside of the alveolar ridge and on the outside alveolar ridge, and we were tractioning down? That will also decompress the ethmoid. But another way to do it is to take the thumb, instead of having it on the teeth, have it on the bridge of the nose and decompress it that way. But it's the same angle, about 60 degrees up like this.
So one finger's on the nose and one finger's on the teeth?
Yeah. So like this, instead of you can do it this way, but you'll, when you move your thumb up onto the nose, you'll get a sense it's a lot more solid.
Sorry.
Does that make sense?
Going which way?
60 degrees out this way. So that, yeah, that's the angle to decompress the vomer and ethmoid. So if you have imagine a line here, and this is 90 degrees here, it would be about like that. So 30 degrees from this line and 60 degrees from this line. Okay? And that'll decompress this vomer. But we can't, it's so isolated back up in there. It's really tucked away. Can't get to it directly. And but it turns out we can work it, and having a nice malleable ethmoid is important for free motion of all this area, because otherwise if it's that stiff, then these things can't move up and these can't move down during flexion.
You know, when it comes to the bones of the skull, it looks like to me like if one, it's almost like impossible to have one only functional, because they connected so much. So if there's one a little skew, the other one's going to be impacted one way or another.
Exactly. And that's why sometimes it's a challenge to find the primary one.
Okay. To find the primary one, that's the key thing.
Yeah, and sometimes you can, like, if you're freeing up the maxilla, for example, but the primary restriction is a palatine or something, the restriction will usually just come right back again. So you have to explain to people that, you know, it's a process to find. Sometimes we have to peel down through layers or try different things, because you won't always just intuitively be led to the primary restriction. Yeah, and almost all these little restrictions will feed back into the cranial base, and you'll feel them on the sphenoid. But creating out the sphenoid is often not enough to keep it. So that's why we're learning all these different tools, and you want to be able to choose to listen in and say, okay, is there a lesion here? Is there a lesion here? Is there a lesion here? To help track it down. And you'll notice, okay, well, this lesion's causing this, and it's causing that over here. It's like dominoes. And you're exactly right. That's what makes this so complicated. Okay? But come play with these models, because the anatomy is fairly complex. This is one of the more intricate jigsaw puzzles in nature. But that's what we work with. And it's really cool once you see it. Okay? And I didn't get, my first few times through this stuff, I didn't get it very well, because I didn't spend time looking at the models and looking at the anatomy and thinking about how the bones move during the flexion extension.
The pterygoid processes are attached to the...
They're part of the sphenoid.
They're part of the... Oh, okay, that makes
Yeah.
sense. Okay, that's the lower part of the...
And so if you take your tongue, and again, you go back off onto your soft palate, but then go off to the side, there's a knob there underneath the skin. That's the tip of your pterygoid process.
Ooh, that was that far.
Go off to the side.
And then we'll go back that far?
Like a sheep.
For the knob?
Yeah. So go straight back and then up to the side. And,
Okay.
and there's a knob there. And if you go lateral to the knob, you go back at the end of your teeth, right? Yeah. But that's your pterygoid process.
Okay,
So technically we could work it through the mouth, but it'd be cool to, you know, if you could feel the pterygoid process while you have your hand on the greater wings and feel how it's all one bone and see how it moves and stuff.
How often do you actually do these moves where you have fingers and teeth into mouth?
It's fairly common.
It's very common.
Yeah. I actually don't, you know, my back's getting better, but it was bad for so long, and, you know, working in the mouth, you're standing up and leaning over, and so I didn't really like working in people's mouths for a long time until I developed ways to do it without having to work in their mouth.
Really?
Yeah, and I can show you some of the releases, but they're not as efficient as the actual working mouth. Yeah.
So
But,
it's also a question of building trust with the client. I mean, you know, if I haven't built trust with the practitioner, I can hardly see that I would open my mouth and let them get in there.
right.
I mean, and that's my personal thing, I get it, but, you know, I would believe other people have that.
Oh, yeah. I mean, the mouth is a very frequently traumatized area, and you know, a lot of the way that children are sexually abused is to be forced to perform fellatio, and that will make them really sensitive around their mouth and stuff. And so you do have to develop trust. You have to explain ahead of time what you're doing and why you need to go in there and do that. And but generally, after you've worked on somebody a few times, and hopefully you know their history pretty well by then, that kind of thing, getting that trust. Yeah. But there's ways to work, like you can work the maxilla from out here with just the fingers on the teeth and stuff, and you can do torsion and lateral strain and compression, that kind of stuff right from here. You don't need to go into the mouth. It's a little harder to work the palatines outside, but anyway, that does that ethmoid make sense? Just the sort of the anatomy, how it works. So the ethmoid